There is a scene in the movie entitled The Aviator in which Howard Hughes, who is played by Leonardo DiCaprio, is stuck in a bathroom because he cannot touch the door handle. And this is before the times of having disposable sanitary napkins or towelettes where you could just grab the handle with the towel. So he has to wait there for a long period of time until another user of the bathroom enters and he could then slip out. Um, Howard Hughes is the most famous celebrity who suffers from OCD, but there are other celebrities that you may know. Recently, or in the last 10 years, Howie Mandel, who is a comedian and host of Deal or No Deal, came out as also suffering from OCD. And you could watch several of his interviews about obsessive compulsive disorder here on YouTube. So I recommend you might look at that to see a real life example of somebody who suffers from obsessive compulsive disorder. Obsessive compulsive disorder encompasses a lot of different ways of expressing the anxiety. And touching door handles or being afraid of contamination is just one element of several that could exist. We live in a culture of sanitation. Everywhere you go, in the classroom I used to teach at last year, the school supplies that were given to teachers were not just pencils and paper and markers, but also every teacher will be given gallons and gallons of hand sanitizer. You go to the hospital, you go to the bank, you go to the school, and you see it everywhere. So in a way, we're almost enabling this sort of mentality that everything is contaminated. But even if you feel that everything is contaminated and you're afraid of touching things like handles on subways or door handles or shaking people's hands, the question is it severe enough to be diagnosed as OCD? So let's actually talk about the diagnostic criteria for OCD. We'll start off with definitions and then we'll go to symptoms. So what is OCD? As I had just said, it stands for obsessive compulsive disorder. A mistake that I've seen students make is that they often don't distinguish between the obsessions and the compulsions. So let me just make sure that there's a distinction between the two. Obsessions are unwanted or intrusive thoughts, so they're internal, whereas compulsions are more about things you could see or behaviors. The way things usually go is that the obsessions, the unwanted thoughts, lead to the compulsions. And when you do a compulsion, when you engage in that behavior, it alleviates the anxiety. So it gives you a sense of relief. Unfortunately, the sense of relief is usually short term because the obsession will come back and then you'll need to do the compulsion again. There are various statistics about the prevalence of OCD, and roughly about 2 to 3% of the general population would meet the criteria for OCD. Now, if you wanted to actually differentiate between those who suffer from both obsessions and compulsions, the vast majority have both, which is 69%. Just obsessions is roughly 25%, and just compulsions is 6%. So usually the two go hand in hand. If you look at the DSM-5 criteria for OCD, you could probably make some predictions about what the criteria are based on just what we spoke about. So the first criteria are recurrent and persistent thoughts, urges, or images that are experienced at some time during the disturbance as intrusive and unwanted. So as much as you try to fight the thought just keeps creeping into your head and it causes you some distress. As we saw with the Howard Hughes examples, repetitive behaviors can include things like hand washing, but it could also include things like putting things in a certain order or checking things over and over again. Some of you may have experienced the feeling of, did I lock that door? And you check it to make sure it's locked, or did I leave that oven on? And you check the gas to make sure it's not in the on position. Imagine that feeling all the time where you have to do it repetitively and maybe even a certain number of times. So that would be an example of checking. Other things could be mental acts. So that could include internal prayers or counting things or repeating words silently to yourself. So I think a lot of us experience these types of symptoms, but how does the OCD patient differ from us is how much time it will take out of your day. So maybe you're losing a few minutes to these checking or ritualizing behaviors, but in order to meet the criteria, you have to be losing at least an hour a day to them. So we may have something on a spectrum of these types of symptoms, but when does it cross the line? It crosses the line at an hour. As with most disorders, you have to rule out that it's due to any sort of medication or drug use, um, and it can't be explained by other disorders. What makes OCD different than perhaps things like schizophrenia or anything else you've studied is that often the person who suffers from the disorder is self-aware of it, and this is what we call insight. So if you look at the DSM-5, it says that people who suffer tend to be self-aware of their own condition and how irrational it is. So the example the book gives is it says, the person may realize that if they don't check the oven or the stove 30 times, they're rational enough beings to realize that the house will likely not burn down. So even if they are self-aware of the irrationality of their behaviors, it doesn't make a difference into whether they're going to do it or not. And it says that only 4% or less of the OCD population are without insight into how irrational their thoughts may be. The syllabus recommends a case study to us so we could provide an example of someone who suffers from OCD. And the syllabus recommends we read about Charles from the book The Boy Who Couldn't Stop Washing, written by Judith Rappaport in 1989. Now, this book deals with several case studies, not just Charles, and Charles is not his real name. It's a pseudonym to, protect the confidentiality of the OCD sufferer. And this book is credited with bringing OCD into the public light about what it actually is. And, before 1989, it wasn't necessarily a household phrase. To call somebody OCD nowadays is kind of commonplace. So let me just share a few of the details of this case study, and I'll read verbatim here. Charles, he would hold the soap under the water spray for 1 minute in his right hand and then out of the water for 1 minute in his left hand. He would repeat this for at least an hour. So we've already met one of the criteria for him to be formally diagnosed as OCD. He's already losing an hour in the shower. And it gets worse because after washing for about 3 hours, he would then spend another 2 hours or so getting dressed. And as far as the insight, even though he's a young man, he, like many OCD sufferers, was aware that his behavior appeared crazy to others, but he himself didn't feel crazy. Like many OCD sufferers, Charles showed insight into his condition. And that's interesting when talking about treatment because we know that CBT is a common treatment for multiple disorders, including OCD. However, unlike other things like depression, where maybe the person is not aware of his own irrationality, an OCD sufferer usually is. So maybe we have to use a little bit of a different methodology besides rational emotive behavioral therapy. Maybe we have to use something that's more designed for OCD, and we'll talk about that later. There's something called ERP, or exposure and response prevention. Let's first talk about measuring OCD. There are several scales, multiple scales, almost too many scales for measuring OCD, but the syllabus recommends 2 of them to us. I usually like to start off with one that's not on the syllabus. That's called the OCIR, and that's the Obsessive Compulsive Inventory Revised version. And I like to use the OCIR because it is widely available on the internet if you want to have a look at it, and also because it has subcategories or subscales that are absent on the one that is recommended by the syllabus, which is the MOCI, and we'll talk about that one in just a few moments. But if you look at the OCIR, it's broken down into 6 distinct subcategories. There's washing, which is typical, checking, which is typical, ordering, obsessing, and then you have 2 words that you may not have seen before in relation to OCD. One is hoarding, and that is when you collect a lot of materials and you have a hard time letting go of them. So a OCD sufferer may often save things even if they're not needed in the future. So if you know somebody who has a room full of stuff, maybe old magazines from 20 years ago, things that you can't imagine having any practical use, this might be an outward sign of some sort of OCD. And the other one is neutralizing, which another way of saying that is perhaps ritualizing or doing a ritual that will negate some sort of bad or intrusive thought. So just to come up with my own example of this, let's say you have a thought that makes you uncomfortable. Maybe you think about um, some person who you don't like, or you see a person you don't like. You touch your forehead 4 times, and then tug your left ear, and then tug your right ear, or something like this. Some sort of manifestation or ritual that will undo the bad thought. Okay, and there's a look at the OCIR. It's a Likert scale-based assessment. But as I said before, the syllabus is recommending that we look at the MOCI. And there's also something called the Vancouver Obsessive Compulsive Inventory, but let's not worry about that. But there's a lot of overlap in these inventories, okay? All of them assess checking, but the MOCI subcategories are just 4. Checking, cleaning, slowness, and doubting. Slowness is that subcategory that shows that a simple task will take longer for somebody with obsessive compulsive disorder. They may take twice as long to get dressed as somebody else, and that goes hand in hand with that loss of time that we talked about in the diagnostic criteria. Doubting might be that feeling that you can't make an easy decision. Maybe it's a subcategory, or it's related to being a perfectionist. You have to do everything just right. The MOCI is not as readily available on the internet, so that's why I sometimes have the students create their own MOCI based on what we know about it. You could find some questions on the internet, but it's really hard to find all of them together. Just know that there are 30 items altogether, and they are binary choices or forced choices of true or false, and that there are 4 subcategories. And here are some examples of some questions that I was able to find, but I can't find all 30 very easily. And if you ever have to evaluate the MOCI, I think it's a rather easy one to evaluate simply because it has a forced choice of true or false. So unlike something with a Likert scale or something with more qualitative data, this is going to have very limited quantitative data, just a binary yes or no or true or false. That could also be a good thing, though, because then it's easy to collate that data and to pull it together into a score. So it's quick is the good thing. It lacks nuance is the negative. So that makes it for an interesting contrast with a more popularly used measurement tool nowadays, which is the Yale-Brown Obsessive Compulsive Scale, also sometimes called the Y-box. And you could actually find some of this in various textbooks, some example questions from the Y-box, but they're not going to give you the whole thing because it is a rather long and comprehensive questionnaire. And it has various ways to measure. So some of the questions are multiple choice, some of the questions are rating scales, and some of the questions allow for some sentences or qualitative feedback. And this could often be done in the presence of a therapist. So there is some sort of guidance there. You're not just left on your own to fill out the Y box. And you're going to see reference to the Y box in various studies that are recommended by the syllabus, and we'll come across this tool yet again. All right, before we get to the treatments and the various case studies or recommended studies, let's go to theories of OCD. This is one of the few places in the syllabus where we actually get to talk about the psychodynamic approach. We talked about it briefly when we talked about phobias, Little Hans and the Horse. You know, Sigmund Freud, as I've said many times, is not as relevant to the 21st century as he used to be, but it's important to know where psychology comes from or the early foundations of psychology, and there are still a handful of practitioners who still use some sort of psychodynamic or psychoanalytic approach. Most conditions in psychology are blamed on experiences in early childhood. So you may remember some of this about the Oedipus complex with the phobias and Hans and the Horse, but now we're moving on to a different stage, a psychosexual stage of development, and that has to do with the stage in which the child is learning how to be clean when he relieves himself or uses the lavatory. I'm trying to avoid using colorful language here, but essentially when the kid is doing number 2. So this is the anal phase, okay, from the ages of 2 to 3 years old. And this is what we call potty training or toilet training. And the child learns to respond to some of the demands of society You can't just poop or pee anywhere. You actually have to expulse your feces into a toilet. And this could be a very contentious time between a parent and a child. There's a lot of trial and error here. There's a lot of demands made on the child about when to use the bathroom and when not to use the bathroom. So if this stage has some sort of deep conflict, if the child is very paranoid about using the bathroom, he may retain his feces or be anal retentive. And you may have heard that term used before about a person who is extraordinarily neat. So if the child holds back his fecal matter, I'm sorry to laugh, but it's hard for me to say these things in very diplomatic ways, he or she will develop some sort of neuroses about cleanliness in the future. So you have anal retentive people who retain their fecal matter, and you have anal expulsive people who are more free about using the bathroom at any given moment. Of course, psychodynamic or psychoanalytic thought was replaced in the 20th century largely by behaviorism. So the behaviorist may look at behavior in terms of things like reinforcement. In this case, it would be negative reinforcement, because if we're dealing with the hand washing ritual, the thought that your hands are dirty needs to be alleviated or removed through the washing of the hands. So negative reinforcement is the removal of something unpleasant, and this goes along with what we term operant conditioning. And if you're not remembering any of this stuff with operant conditioning or negative reinforcement, you may want to look back at the phobia unit, where we talk in more detailed terms about what operant conditioning is versus classical conditioning. So simply put, you feel something negative, you remove that negativity, and now you feel a sense of relief. The problem here, of course, as we said earlier, is that the unpleasant thought is going to return. So why does that unpleasant thought actually return? We might have to go beyond behaviorism and actually look at more of a neurological or physiological point of view to figure this out. All right, so we have to go into the realm of the neurological or brain structure. There are several case studies that lend credence to the idea that there is a region of the brain known as the basal ganglia, and more specifically the caudate nucleus, that regulate the person's ability or anybody's ability to stop an action. And this part of the brain is associated with sending warnings to a person about outside threats. So in this case, the outside threat could be something like germs or contamination. The caudate nucleus is known also as a gear shift. It tells us that an action has been completed and that we can move on to other actions. Now, several case studies have shown that lesions made in the brain through perhaps surgery or the removal of a brain tumor have actually induced OCD into people who didn't show any symptoms before. So here I have an article, very small, hard to see to the right, about a woman who had a brain tumor removed that was around the basal ganglia region. And the lesion is shown in that picture there, the area of the lesion, caused her to all of a sudden develop symptoms of OCD, and all of a sudden she could not even leave her house for fear of contamination. So she's definitely suffering from both social and occupational malfunction. And here, it's hard to see here, but I believe it does mention the YBOCS, or the Yale-Brown Obsessive Compulsive Scale, also reported that she indeed was all of a sudden at the age of 36 a person who met the criteria for obsessive compulsive disorder. So that's quite convincing evidence that there is a physiological or neurological element to OCD. Now, of course, when you talk about physiological and neurological elements, there's probably going to be some genetic issues at play here. So let's move on to that. So the Russell textbook we've been using this year highlights 3 possible genetic culprits for OCD. Now, I'm not a big fan of just memorizing things without understanding, but when it comes to genetic code or genetic abbreviation, sometimes I just tell the students, you might want to just memorize a few of them, maybe one of them, just in case a question were to come up. Because I don't think the purpose of education is just to memorize things. Of the 3 genes that are listed here, DRD4 might be the easiest to remember because you already know the words associated with the abbreviation from our discussions about schizophrenia. DRD4, I believe, stands for dopamine receptor D4. So the D4 receptor for dopamine is associated with this gene. The other two that were pinpointed by Mathiasen et al., PTPRD and SLITRK3, might be a little bit more difficult to memorize. But when you talk about the Mathiasen study that is associated with this, you might find it to be useful in that it is very good in the number of participants gathered in this study. So it was over 1,000 families gathered with nearly 1,400 patients with OCD and nearing 3,000 individuals in total in the study. So, of course, if you have that many people involved in a study, it's going to be strong in generalizability. And if you want to pause this slide and look at more details about the sample, I invite you to do that. But going back real quick, another problem I have with these three genes being identified, especially DRD4, is that it sort of contradicts what I was taught about OCD. Also, as somebody who was diagnosed with OCD in my teenage years, my therapists and my teachers told me that the main culprit in OCD was not necessarily dopamine, but serotonin. Dopamine seems to be the usual suspect for almost every disorder. And there's a joke that DRD4 is the repeat offender of psychology. DRD4 has been associated with things like ADHD, schizophrenia, alcoholism, and now it's being implicated also in OCD. It seems to be a wreak havoc gene, if you will. So again, you can know these or know one or two of these and maybe know a little bit about the Mathiasen research that is filled with a lot of jargon, genetic jargon, which honestly I am not 100% on, but I could easily see that that sample is quite strong. So again, I said that the neurotransmitter implicated was not dopamine necessarily, it was serotonin deficiency. And this has been the prevalent belief for quite some time, since at least the 1980s. So we should know by now, if serotonin is the problem, if there is a deficiency, based on what we know from the depression unit or the bipolar unit, when something is in deficiency, we probably want to prescribe something that blocks its reuptake, in this case an SSRI, a selective serotonin reuptake inhibitor. And the most popular, or at least when I was diagnosed, the most popular medication in the 90s at least, was something called anafranil. And if you read in more detail the case study that Judith Rappaport presents with Charles, the boy who could not stop blushing, he also took anafranil. The problem with drugs, of course, is that you're going to eventually need to up the dosage as you build a tolerance to those drugs. And I believe Charles, like many people who take anafranil, the benefits were not long lasting. They had to keep upping the dosage to match the gains from the drug. So by talking about anafranil and SSRIs, we've already previewed one of the treatments for OCD. Some of the other treatments involve talking therapies. As we said before, CBT might work, but not REBT necessarily, because that models irrational, that combats irrational thoughts by pointing out the irrational thoughts to the client. But we said before that the client may have great insight into his own problem. So therefore, we're going to talk mostly about something called ERP, exposure and response prevention. Also, it's recommended that you could also use some sort of imaginal desensitization, where a patient visualizes images that stress him or her as they go through relaxation techniques. So what is exposure and response prevention? Therapy is very similar to systematic desensitization that we talked about with phobias. So it is based on the notion of reciprocal inhibition. So what that means is that you cannot be both stressed and relaxed at the same time. But the difference is that the anxiety is internally generated, not from some sort of external stimuli like a spider or something like that. So something else needs to happen during this sort of relaxation therapy, and you need to stop the person from engaging in the compulsion. So as the person slowly has his anxiety dissipate, as he's not doing the compulsion. So, for example, you're going to touch this computer keyboard and you're not going to wash your hands afterwards, even though you know other people touch that keyboard. And it's going to be very anxious for the first few minutes, and then eventually that anxiety is going to dissipate and you're going to habituate yourself to the situation. You're going to calm down. And just like with systematic desensitization, it's very helpful to have some sort of fear hierarchy or some sort of SUDS scale or fear thermometer, so the therapist knows where to climb next, where we can go after we've succeeded on the lower rungs of the ladder. So if you look at this little thing on the left here that charts how OCD works, you got the obsession to the anxiety to the compulsion that relieves it. You're going to sit on your hands, or you, metaphorically speaking, so the compulsion doesn't actually happen. So does ERP actually work? Well, according to Lavelle et al., not only does it work, but it also works via telephone. And this is one of the studies highlighted in the syllabus, so you may want to pay some mind to some of its details. The hypothesis was that ERP therapy would work whether it was face-to-face or done by phone. Okay, the results are going to be similar. The experimental design is independent groups, and it is highlighted in the text as a randomized controlled non-inferiority trial. A non-inferiority trial is trying to determine a lack of inferiority, or that something is not weaker than another thing. So usually if there's a new therapy or new medication, you want to do what's called a non-inferiority trial to show that there are going to be similar results for two treatments. A few things you can know about the participants is how many there were. There were 72, and they were all involved in an outpatient treatment center in Manchester, the United Kingdom. And they scored similarly on the Y-box with at least a score of 16. The age range is pretty high. It's from 16 to 65, so that's quite a gamut of ages. I guess that could influence the generalizability of the study. And lastly, they excluded patients who may have had variables that would have ruined the validity of the study. So, for example, if they were taking antidepressants, or if they had some sort of severe depression or substance misuse, perhaps using illegal substances. So originally there were more participants, but they had to get rid of some because the participant variables would be confounding to the study. So simply put again, the IVs of the study are you doing face-to-face ERP, or are you doing it by phone? Now, since this study is published, we're probably going to guess that the hypothesis is true. Therefore, the most important piece of information from the results is that there will be no difference in the baseline scores for the two conditions. And there were two measures used, actually. We already talked about the Yale-Brown Obsessive-Compulsive Scale, but they also used the Beck Depression Inventory, sort of like a backup. But you could also say that people who suffer from OCD would tend to be depressed about their conditions. While not a longitudinal study, there was a 6-month follow-up. So they visited the patients again and asked them to do the Yale-Brown Obsessive-Compulsive Scale once more, and the score remained lower for both groups. And just one more piece of information for the results. The satisfaction rate for the patients was nearly the same. So whether you were telephone or face-to-face, you were equally satisfied with the results. For the evaluation of the study, we could say that because the participant variables were removed, or as much as possible removed, by getting rid of people who were on antidepressants or on illegal substances, this increases the validity. They used the YBOCS and the BDI, which are both shown to be both valid and reliable, so the use of those tests make the study itself more reliable and valid. The people who were administering the measures were blind to what condition the participants were in. So because they were blind to it, this also increases validity because there's not going to be any sort of confirmation bias on the part of the examiners or the testers that are giving these measures. There was a therapist manual and supervision, so the reliability is high because you want to make sure you're allocating similar treatments across all groups. And like we said before, there's high patient satisfaction, so this makes the study uh, rather strong in ethics. A weakness of the study could be that there was no inclusion of a control group, and they mentioned this at the end of the study as a limitation. They could have included a non-treatment group, but I think they felt they had enough data from other studies on non-treatment groups that they did not need to include one themselves. Perhaps another weakness would be that the people who were involved in the study were on a long waiting list for the clinic, which may mean they were quite eager to get involved with the treatment. So these participants might have had a similar characteristic of being very willing or highly motivated participants. So this study, while not giving us the exact recipe for ERP, does show us the efficacy of ERP regardless of how it is delivered. Another study on the syllabus that gives us more of a recipe of how ERP is done by someone named Lemkel et al. From 2008. And now this is a case study, so immediately you should know by now that it's going to have an evaluative problem of generalizability. But what makes this study even less generalizable for OCD is that the participant, who is called Jason here, also has autism. Okay, so this is a very special situation. Regardless of how special the situation is, however, the printed study does give us a better look at the details of what ERP entails. They sort of break down these sessions into what happens during these therapy meetings. Participant details, Jason is not his real name, of course. He's 12 years old and he's white. Not sure why white is significant, but the study mentions it. He's diagnosed with autism and OCD, no history of trauma, and his IQ is normal. There is lots of evidence of autism, and autism tends to show itself earlier than OCD. So around the age of 2, it was clear that he was showing poor expression and he had poor social relations. And he was also showing symptoms of echolalia, is when you repeat things that other people had said. You're echoing what they're saying. The evidence of OCD came around the age of 12. He would perform rituals. He would show deep fears of contamination. In the school classroom, he wouldn't even turn pages of a book if that book was like a publicly used textbook. If it was a private book, he could probably more easily turn pages. He would excessively use hand sanitizer and avoid any sort of doorknobs. And he had a lot of checking behavior. And the example in the study is that he would check the expiration dates of food and be very, very paranoid about if food had been expired. He scored 18 on the CYOBCS. So the C stands for the children's version. So it's the children's Y box. The treatment for his OCD lasted 16 weeks across 10 sessions. And I'll just give some highlights of what these sessions entailed. The early sessions were to explain to him what the purpose of the therapy was and to construct a hierarchy of anxiety based on what causes the most distress for him to touch or to feel or to think. And the therapist asked him to separate his OCD concerns from normal concerns. So in other words, what kind of worry is a worry that other people would have, which would be normal, and which type of worry would be just for OCD. So they kind of compartmentalized anxieties into normal anxieties and OCD anxieties. In session 2, Jason touched items in the hospital, so the exposure therapy began rather earlier than usual, and they acknowledged that it began earlier than usual. Usually you want to wait a few more weeks to give people the actual exposure therapy. In sessions 3 to 8, there was a review of homework, so he was asked to touch things in the classroom, and he had to report on various distress he felt when touching these items. And there were also objective measures of his distress. So, for example, if he touched something and he didn't wash or he felt contaminated, you could see his face turning red or something of that nature. And he would also practice making coping statements during the stress. So he would be given sentences that he could say as he's feeling the distress, sort of like a self-affirmation to alleviate the distress. And he was showing much gains in just a few therapy sessions. By session 9, he was much more able to cope and to handle classroom settings and touch things and interact like a normal boy. So these sessions concentrated on coping strategies for preventing relapse. The gains Jason had made were quite remarkable. So, as we said before, he started with a score on the children's version of the Y box at 18, and by the time the treatments had completed, they were only 3. To make sure that the coping strategies were still being used, there was a 3-month follow up, and he had still maintained his positive gains by that point. So, with any type of CBT, keep remembering that there's homework and coping strategies involved, and this is why it tends to have longer benefits than other types of therapy. Think about the Sensky befriending study that was done with schizophrenia, how both the befriending group and the CBT group both made gains, but only the CBT group was able to maintain those gains after what was it, a 9-month follow-up or something like that. Okay, moving on to the strengths of the study. I think this is very helpful in application because it gives something of a blueprint to people who want to start using ERP. So it provides more detail about the recipe or process of ERP. The other strength is very similar to what we just talked about with the level study, is that it's using widely accepted measurement tools that are both valid and reliable, in this case, the children's version of the Y box. The weakness is super obvious. He has both autism and OCD, and the comorbidity rate for having these 2 disorders at the same time is only 2%. So that's going to be a highly specialized situation, which further decreases its generalizability. That being said, though, there is overlap with how you would handle ERP with a non-autistic person. All right, I'm going to not go fully into BDD here because I want to save that for a separate video, and I also need to drink something. So look for our discussion about body dysmorphic disorder in an upcoming video. For now, just know that body dysmorphic disorder is now considered to be a subset of OCD, except rather than obsessing about things like contamination and did I leave the oven on, it's more about your personal appearance and believing that you have these defects that you must correct about your personal appearance. Okay, guys, I'm going to take a break here. Good luck with the studying.